Hello, I'd like to welcome everybody. Thank you for joining us for our session on VEDS pulmonary concerns and medical management. My name is Ryan. I am the director of the VEDS movement division of the Marfan Foundation, and honored to have us honored to have joining us today, Dr. Enid Neptune. Dr. Neptune comes to us from Johns Hopkins Medicine, where she's associate professor of medicine, and also is a member of the Marfan Foundation and the VEDS movement professional advisory boards. So with that, I'd like to welcome Dr. Enid Neptune.
Hello, everyone. I'm going to share my screen with you guys, and so we can get started. And let's see. And so I'm going to talk with you about some of the respiratory and pulmonary considerations with vascular EDS. And I will have to admit initially that this is a challenging disorder to study because it's rare. And so what I invite is for everyone who's attending this webinar, if they have specific questions that we don't have time to address, please put them in the chat and I will follow up through the Marfan Foundation to answer every question. And if there's a theme for my talk, it's that it takes a family to address the medical issues of patients with VEDS. And so you need to construct kind of a medical team of people that you trust and people who can help you fight all the battles that you may have to fight, and will be kind of a source of information that is continuing to evolve within this rapidly changing field. And I have no meaningful disclosures. And I start with this slide, which actually pertains to not just vascular EDS, but other disorders that are within the spectrum of Marfan and related disorders. And as you can see here, I have kind of this circle of kind of diagnoses that we've seen. And I've actually seen all of these with VEDS, and they include the emphysema. And I'm going to give you kind of a rational explanation as to why we see emphysema. We definitely see pneumothorax, which is often related to emphysema and the lung blebs that we can often kind of diagnose on CT scans. We do see some cases of sleep apnea, and we need some more information on this diagnosis. There are also issues in terms of deconditioning and restrictive lung physiology. And the lung restriction is usually kind of a consequence of scoliosis or chest wall issues that can develop as a part of the VEDS spectrum. Now, in the center, I have some of the symptoms that people may report to their doctors. And I have these listed because I know they seem really non-specific, but that is the reason why if you have these symptoms, such as shortness of breath, and there's not a rational explanation as after you've gotten the full cardiac and the imaging workup, that's the point where you really need to consult kind of the pulmonologist, because virtually all of the patients that I see have shortness of breath. And we know how to work up this symptom and look beyond kind of the cardiovascular system to make a diagnosis. Non-cardiac chest pain, and this is something we take very, very seriously in our VEDS patients, because it can represent something that's quite serious. And lastly, cough that's unexplained, especially cough that's associated with coughing up blood, what we call hemoptysis. Now, when you think about VEDS, and this is the way I construct kind of the syndrome, is I think about the mutant protein, which, as all of you know, is type 3 collagen. And then I think about where it's expressed in a given organ to give us a sense of where we might be seeing the impairments or the problems. And we know that it is expressed in the lungs. And we know that it's most likely associated with the structures of air spaces, and those are the alveoli that oxygen goes to in order to be distributed to organs in the body. And it's also expressed in blood vessels, which is why some of the vascular complications that we see in other organs are also manifest in the lung. And we know that VEDS and the mutant collagen that is associated with VEDS results in fragility of the lung tissue and the lung vessels. And that fragility, I want you to all kind of recognize and be able to communicate with some kind of force and consistency to all of the physicians who manage your care. Now, what happens because of this distribution and also the consequences of this? The first thing is that we get lung hemorrhage, and that's a direct consequence of vascular injury and a consequence of the fragility of the blood vessels. We see lung cavities that often follow bleeding episodes, even when the bleeding episodes haven't been clearly diagnosed. I mean, we're fortunate when we can actually see hemoptysis and episodes that are secondary to coughing. But even if we don't, there could be bleeding episodes and bleeding lesions in the lungs that are not diagnosed when they're happening. Lung cysts, and these also follow bleeding episodes, and these are a consequence of abnormal kind of repair and remodeling of the lung tissue after a bleed. And the pneumothorax is really secondary to where these events are occurring. And pneumothoraces occur close to the surface of the lungs. And therefore, if you have a bleeding event and you have a cavity or a cyst in that area, there's a greater likelihood that you're going to have a pneumothorax. And lastly, sleep apnea. And as I said before, we know the least about sleep apnea, and that's where we need to get more information. And I hope that you can kind of help us to understand that better. And when we look at the lungs as a structure and as an organ, this slide kind of gives you a sense of kind of where the issues may be with VEDS. This is what we call an airway, because the lung is constructed of what we call tubes and spheres. And so the tubes are the airways, and they really just conduct air and oxygen out to these structures that are called the alveoli. Now, the alveoli are very thin-walled sacs, tiny, tiny, tiny. And that's where oxygen moves into the walls, into the vessels of the alveolar walls. And that's how we distribute oxygen to all the critical organs in our body. And as you can see, these vessels that are decorating kind of these alveoli. Now, where we see collagen expressed makes perfect sense in terms of some of the complications we see. It's expressed in the pulmonary arteriole, it's in the pulmonary veins, it's expressed in the capillaries, which are the structures that connect the veins and the arteries. It's also expressed in the walls of the alveoli themselves, independent of the vasculature. And so it's this combination of kind of localization that gives us that spectrum of complications that I talked about. Now, in terms of what are the major complications that we see in the lungs from VEDS, this is kind of an unpublished kind of survey of case reports that have been published since kind of 2014. And when we reviewed these and looked at the distribution of pulmonary manifestations in any case report that reported a pulmonary manifestation, we found that most of the time, the pulmonary consequences are the first manifestation of the disorder. And so it's very important that when someone presents with these manifestations, at least there's a consideration that this might be caused by VEDS. And we're really energizing our community and our advocates so that emergency room physicians, when they see patients who actually have these particular manifestations, that they have that on their diagnostic list so that we can manage patients as they need to be managed with this disorder. And as you see here, pneumothorax and hemothorax are very common, as are kind of pulmonary hemorrhage. And when Dr. Shalhoub and I kind of conducted kind of a case series a few years ago, we found that about 18% of all patients with VEDS that were in our study, and these were 96 patients, had a history of pneumothorax or hemothorax. And again, most of the time, this preceded the diagnosis of VEDS. And there was a more recent study that was conducted out of France in which they looked in a single center at 136 patients with VEDS. And they found that 18% had a history of pulmonary complications. But interestingly, more than 50% had abnormal chest CT scan. And so one of the studies that we're conducting at Hopkins is we're reviewing the chest CT scans on all of our patients with VEDS to see if there are themes and patterns that actually resonate with some of the complications that we see in the lungs and elsewhere. Now, this is what I call kind of our provisional pathogenetic scheme of how kind of these lesions develop. What we know is that given the fragility of the lungs, that the lung vessels are very susceptible to any type of trauma. And so we suspect that there's some type of a spontaneous trauma that leads to bleeding in certain areas of the lungs. And so the bleeding typically will stop because bleeding stops because it begins to compress structures that are around it that have kind of increased tension, and that kind of walls off the bleeding. And so we think that there are a few options that the lesion has in terms of resolving itself. It can either form a cavity, and sometimes patients present with cavitary lesions and people are very, very worried about very unusual infections. And I suspect that these can either evolve into a lung cyst, and those are holes in the lungs that some people will actually diagnose as emphysema, or they can form these tight, fibrotic, and scarred down areas that we call lung nodules. And in some patients, we see all three of these manifestations, and in some we see all four. And so what we're trying to do is collect kind of the sequence that these happen so we can validate that this is a course of resolution, and therefore we'll be able to kind of evaluate the stage of the lung kind of involvement based on the prevalence of these particular lesions. And I wanted to show you some examples of this. This is a young patient with VEDS, and as we see here, this is what you call a solid lung nodule. And you're facing the patient, and this is the spine. These are the diaphragms. And these nodules basically develop after a bleed. And then I want you to look at this, and this is a cavitary lesion, a cavity that's kind of in the same location. And what we see is that the cavity evolves into a nodule over time. And this is another cavity where you see that it's far larger, and then it has this surrounding almost halo, which suggests that there's some element of active bleeding. And then as these lesions resolve, what you're left with are these really dark areas, and these are what we call cysts. And so this shows that there's a whole spectrum of lung manifestations that one gets that are associated with that seminal bleed. And so one of the things that we have to understand better is why patients have these bleeding episodes. What are the mechanistic triggers, and what are the types of interventions we can implement in order to prevent the bleeds from recurring? So what do these bleeding events look like? Where they're frequently accompanied by what we call hemoptysis and coughing up blood. And there's a subset of patients with VEDS who have recurrent episodes of what we call low-grade hemoptysis. That means every month or every few months, they cough up a little bit of blood, but it's self-limited. It resolves on its own. What we don't know is the absolute prevalence of these particular symptoms in VEDS. And we hope with our larger registry that is being constructed as we speak, we'll have much more information on the prevalence of hemoptysis and also on its association with some of the imaging findings that I showed you. And so invariably when patients have hemoptysis, they will get a chest X-ray or CT scans. And these can show an infiltrate or just shadows, nodules, as I showed you, lung masses that can be larger than nodules, or in some cases, what we call pleural effusions, or sometimes it's called hemothorax or fluid or bleeding, kind of that surrounds the lungs. Now, what kind of symptoms do patients have? They can have one or all of these, a cough, sometimes with blood produced or hemoptysis, chest pain, sometimes shortness of breath. And the chest pain can often be dull and it can feel more like soreness, but it's usually lateralized. So it's on one side or the other in one particular location. And sometimes a hemorrhage can be an incidental finding on chest X-rays and CT scans. And if the patient does not already have a diagnosis of VEDS, they may undergo an incredibly arduous diagnostic kind of set of studies. And many of the patients that I see have been through an incredibly long and complicated diagnostic workup before VEDS is ultimately found. And so that's not unusual because these lesions are not specific. And to someone who's not familiar with VEDS, they can look like many things. But I should say that often radiologists are the people who are able to make the diagnosis much sooner than any other specialist. And again, evidence of hemorrhage requires immediate medical attention. And so the diagnosis is really based on the clinical presentation, imaging that again can show an infiltrate or a pneumonia, a nodule or cavity. Sometimes, as I said before, there's going to be blood surrounding the lung, what we call in the pleural space. And in certain occasions, depending on how rapidly the bleeding is occurring, a bronchoscopy or a thoracentesis may be needed to confirm the bleeding. And most events develop, as we say, spontaneously, and most are self-limited, but sometimes they can persist with significant blood loss. And what I typically construct with my VEDS patients who have hemoptysis is that we decide what the level of bleeding is that we will consider serious enough that medical attention is required. And sometimes that's a matter of volume, whether it's, a 3 or 4 tablespoons, whether it's kind of bleeding that occurs over 4 to 6 hours, or bleeding associated with chest pain or shortness of breath. And so we establish what we call these thresholds for clinical intervention. And once my patients are past those thresholds, medical attention must be sought. Now, what can you do if the bleeding does not stop? What we know is that some interventions in kind of VEDS have actually been very well tolerated. We're always aware of the tissue fragility issue. And because of that, I strongly, strongly advocate that you identify a center that has some expertise in the management of VEDS patients. And you insist, if you're not in one of those centers, that those centers and those experts be contacted as interventions are being decided upon. And in this case, what we see is the bleeding, which is kind of demonstrated by angiography, where a dye is injected in blood vessels that likely supply the area that's bleeding. And then what the interventional radiologists are able to do is they're able to embolize that area and stop the bleeding. And that is a very, very well described and often very safe procedure. But again, ideally, it should be done in a center that has some familiarity with managing VEDS patients. Now, the other manifestation I want to talk more about is the cystic lung disease that can occur in VEDS. And we see that here with these large dark holes in the lungs. And although it's not always diagnosed as a sequela of lung hemorrhage, I'm very much in support of actually establishing that there is some initial event that's acute that leads to this as a form of resolution, as a form of repair, however imperfect. And these lesions, as you say, are very, very close to the surface of the lungs. And when you see these cysts or emphysematous blebs in this location, that makes the risk of pneumothorax much higher. And the patients that I see with VEDS and pneumothorax almost invariably have had cysts or emphysematous lesions in this peripheral location that creates the risk for the development of pneumothorax. Now, how do we kind of think about pneumothorax and VEDS? It's a minor diagnostic criteria for VEDS. It's more common in young men and boys compared to women. And we all know that males have the more serious kind of manifestations of VEDS. And as I said before, it often precedes the diagnosis of VEDS. Pneumothorax is really what we call lung collapse, where the lung detaches from the chest wall. And I'll show you an image of that. And the symptoms are usually the acute onset of pleuritic chest pain, shortness of breath, and a dry cough. And it's really diagnosed by imaging. And this is a schematic that shows what happens with the pneumothorax. Here you see kind of a lung that has some type of a rent or some type of a wound on its surface. And this allows air to escape into this pocket that surrounds the lung, what we call the pleural space. And when you're looking at an X-ray, this is what it looks like, where you see the lung that's collapsed here. And this is all kind of air that's surrounding the lung and compressing it. And so this compression of the lung is what causes kind of the shortness of breath and the reduction in the oxygen levels. And that detachment of the lung from the wall is what causes the pain. So how do we treat a pneumothorax? If it's small, patients can usually be managed with supplemental oxygen. And I'm very much kind of an advocate of, if you have VEDS and you have a pneumothorax and it requires monitoring and is not resolving on its own in an emergency room, you need to be hospitalized. You need to be given oxygen. And if it doesn't improve, then a consideration needs to be made for evacuation. And evacuation is usually with a large catheter, or usually not with a large catheter, actually a small catheter, pigtail catheter. That's usually used if the pneumothorax is moderate or large. And this catheter is placed on suction, and so the air surrounding the lungs are effectively sucked out. In patients who do not have VEDS, they can often go home with these catheters and come back in a few days. But in the case of VEDS, we have to be very, very cautious with that type of an instrument. And I think it's safer to kind of monitor patients within kind of the hospital setting. If the chest tube does not resolve the pneumothorax and it remains large, then a pleurodesis may be indicated. And this is an intervention that will require some trauma or irritation of the chest wall and of the lungs. And you put them together almost like a Velcro strip so that the lung is attached to the chest wall. This is definitely a procedure that you want to have done in a center that can manage kind of the tissue issues that are associated with VEDS. And my patients, I insist that before any procedure is done on them at any hospital, that the team calls me and we review the x-rays and we make sure that the surgeon is aware that there is a tissue challenge when we do any type of invasive procedure on these patients. Now, what are the indications for surgery? And surgery will include the pleurodesis, but also the removal of the bleb, or that large air sac that was ruptured in order to generate the pneumothorax. The indications are usually if you have poor re-expansion, if the pneumothorax is coming back again and again and again, and that means you're hospitalized or you're seen in an emergency room several times over, a year or two for the same issue. If there's an air leak, which means that the hole hasn't healed up and it continues to leak. If you have pneumothorax on both sides, which is a major challenge. If there's not just air, but there's also blood in the pleural space, what we call a hemopneumothorax. And if there's what we call a tension pneumothorax, where the air is actually pressurized and is pushing not just the lung, but pushing all structures in the thorax and can cause some cardiovascular compromise too. And this slide kind of shows kind of what it looks like when the surgeons actually identify where the bleb is and they tie it off and they sew it. And then they're able to actually remove the bleb completely. And so what are the take-home messages about pneumothorax? First of all, we know that it's a manifestation of VEDS, and we know that pulmonary consultation should be obtained with every episode, and that any intervention should have a strong consideration of the tissue fragility and involve experts on the management of VEDS, and that if there needs to be a surgical intervention, mechanical pleurodesis is preferred to chemical, because chemical involves introducing a scarring chemical into the pleural space that will invariably cause a large degree of scarring and a large degree of bleeding. And so we discourage the use of chemical pleurodesis and actually prefer mechanical pleurodesis, which allows much greater control. And I also wanted to kind of alert you to some of the abnormal imaging findings that we see in VEDS. And this includes the cysts and cavities that could represent a superinfection or pneumothorax, and can also lead to progressive respiratory impairment. So any patient that has lung issues, either hemorrhage or pneumothorax or blebs, should have serial pulmonary function testing to see whether the lung function is slowly declining because of the replacement of normal lung tissue with either the cysts or the emphysematous areas or the scar tissue, as we described. And so these are the take-home messages. I want you to be aware that pulmonary complications are often the initial manifestation, and they precede other complications, maybe by months to years. And they should be managed by lung specialists that are informed by those with expertise in VEDS. There has to be caution with invasive or surgical procedures. Team medicine is really the best approach. And those of us who are at centers like Hopkins, in which we see a large number of these patients, we welcome your consultation and your physicians at your local hospital consulting us about these types of cases. And you need to identify a go-to center with VEDS expertise that are available for consultation, are available to kind of express and to get answers to any questions that you may have. And this is my contact information and my email, and the Marfan Foundation has this. So if anyone needs to contact me about any kind of clinical issue and consultation, or they want to come and see us at Hopkins, we are happy to come and see them. And on that note, I will end my presentation, and I invite any and all questions.
Thank you, Dr. Neptune. You'd think because it's digital, I'd be able to get up front stage a lot faster.
Oh,
Um,
good.
but it takes a moment to process. We do have a couple of questions. Jamie, I don't know if you wanted to handle the Q&A. I'm happy to do it as well.
Sure. I will handle the Q&A if you want to monitor the chat, Ryan.
Sounds good.
We've got a question. Are pulmonary embolisms a problem that is associated with VEDS?
We haven't seen many cases of pulmonary emboli. We have seen kind of a couple of cases of thrombosis, but we suspect that that occurs when the bleeding is very, very close to a vessel, and it's actually pushing on the vessel that can produce a thrombus. But we think as part of the kind of natural spectrum, we really don't see them very often.
Okay, next question is, are there any precautions or awareness of the unusual conditions that should be considered in standard pulmonary function testing for suspected exercise-induced asthma?
For a diagnosis kind of asthma requires kind of a couple of things. It requires kind of a compatible history where a person has kind of typically intermittent episodes of shortness of breath, wheezing, maybe cough, that can be worsened with exercise or worsened actually with lying down. And the second kind of supportive diagnostic evaluation involves pulmonary function testing. But the caution is that you can have asthma and have totally normal pulmonary function testing. So the history is more important than the pulmonary function test. And the second issue to really think about is how the asthma is managed, because typically asthma requires the use of medications that are called beta agonists. And beta agonists actually work kind of in opposition to what we call beta blockers, which we use in patients with Marfan syndrome, and occasionally in patients with VEDS, but not as commonly. And so if beta agonists are used, it should be with the awareness that if it leads to kind of fast heart rates, higher blood pressures, then there needs to be kind of an adjustment in the asthma regimen. But the diagnosis actually should be kind of one that's taken very seriously, and a management plan that is integrated with kind of the diagnostic and the therapeutic evaluation of VEDS should be kind of combined.
Thank you. The Q&A is popping off. Thank you everyone for submitting your questions. We will keep going. At what age do we typically see first onset of these symptoms in boys? I'm assuming pneumothorax symptoms.
It varies. I mean, when we did the case series, you can see it as young as in the teens. And we know that the first manifestations of VEDS are usually before the age of 40. And in boys, it shifts a little earlier than it is in girls. And so my feeling, and this has not been a part of a general guideline, and I'm hoping within the foreseeable future we include it, is that any person under the age of 40 that presents with a spontaneous pneumothorax in emergency room will have some type of genetic follow-up in order to make sure that we capture this small number of persons who have undiagnosed VEDS, because as we all know, that is a diagnosis that is critical to make as early as possible.
Absolutely. Our next question is, if there have been no pulmonary issues to date, this person has 20 plus years since diagnosis, should there be monitoring to look for cysts, emphysema, nodules?
I think if you have absolutely no pulmonary issues and you have a diagnosis of VEDS, I think it's useful to have a baseline CT or imaging scan. And why would I say that? I say that because for virtually all of these matrix disorders, when you have a pulmonary issue, the first question someone asks is, do you have a prior scan or a prior imaging study? And so what that means is that because there are these concerns about these lesions developing, it's always good to have a baseline chest x-ray and if possible, a baseline CT scan, if only to assert that your prior studies were completely negative.
Great. Any early indications that lung issues are going to happen in the future with VEDS, or are they spontaneous?
For the most part, these are spontaneous. And what we're hoping to do with the registry and the cohorts is that we're hoping to identify some of the blood biomarkers that associate with these different outcomes, be they GI tract outcomes, be they aortic outcomes, be they kind of medium-sized arterial vessel outcomes. And that's kind of one of the reasons why the community of physicians who manage these patients really have to work together. Because in order to validate candidate biomarkers, we need a sufficient number of patients with VEDS that have kind of the spectrum of kind of manifestations and outcomes that we're able to measure. And that's the value of the Marfan Foundation and what we're trying to achieve with the VEDS community efforts.
Great. I think some of our other questions in the Q&A are a little more specific, and we will perhaps have you answer those offline, Dr. Neptune.
That'll be fine.
Perfect. We will make sure everyone gets connected. We have a few more minutes if anyone wants to get some last minute questions in the chat or in the Q&A. We'll just leave the floor open for a few more minutes.
And I encourage you to kind of contact us, those of us who see patients with VEDS, and to kind of use our familiarity with the disorder. There are far more questions now with VEDS than there are kind of answers, but we can see how these answers are going to occur because of some of the advanced tools that we have with the animal models, with our various kind of investigative platforms where we can look at different genes and we can look at different proteins and kind of a big data type analyses. And so those of us who are committed to this disorder kind of see a very optimistic future where we will be gathering more and more information that will lead to more effective interventions.
All right, a few more questions for you. Can an MRI/MRA provide that data about cysts and pneumothorax? So the imaging you referred to.
I wish it could. I mean, one of the kind of deficiencies of MRA kind of monitoring is that it's not very suitable for the detail that we need in the lung. And that's because those are what we call gated studies, meaning that you have to kind of coordinate the imaging with some type of a regular event. And for vascular structures, because your heart rate is something that can be measured and you can generate the timing of the imaging. But with breathing, it's not so regular that one could do that. And so for my patients, what we do is that we work with our vascular surgeons and our geneticists and cardiologists and come up with kind of an alternating kind of monitoring scheme where we get a CT scan one year and then we get an MRA the next year, so we can cover all of the kind of affected systems.
Thank you. Do certain activities like exercise tend to prompt lung issues in VEDS?
Actually, I don't think so. And that's, and I say that because many of the patients who have these issues like hemorrhage and pneumothoraces, they worry that if they exercise, or they worry if they have like an upper respiratory infection or something where they're coughing, that they can trigger one of these episodes. And there's no evidence that those types of issues are related to the bleeding. The bleeding seems to be incredibly spontaneous. And that's why what we're hoping is that we can identify biomarkers. And ideally, the biomarker would be able to predict whether there's a high likelihood of a bleed happening. And even better would be interventions to deal with these bleeding episodes before they actually develop in any of the kind of affected organs.
If breathing tests get worse from VEDS, are there ways to improve them?
Yeah, I mean, that's why it's so important that a referral be made to a pulmonologist if there are any pulmonary manifestations. What we can do is we can actually set kind of in place kind of a plan of attack for any issues that lead to impaired lung function. We can do a full evaluation of what the causes are. We can actually see what types of treatments might be effective in improving kind of the lung function. And we can give you an awareness of how this plays into the larger considerations for VEDS. So you may have to actually ask for a pulmonary consultation, because for some physicians who manage VEDS and other rare disorders, they don't see the connection between kind of these matrix disorders and what can possibly happen in the lungs.
Okay. Does smoking increase the chances of a breathing episode or a pulmonary episode?
Yeah, smoking does. And I'm sure for the young people that are on the call, the question is, does vaping do the same thing? We have very little data when it comes to vaping. And as someone who's very involved in the tobacco control movement, I actively discourage young people from vaping at all because of the risk of a kind of material kind of getting into the lungs that can cause problems like we saw a few years ago. But smoking definitely has to be actively discouraged in anyone who has a matrix disorder, because the lungs are typically very fragile for patients who have VEDS, and there are often lung manifestations for these other disorders, and therefore why add to the problem by insulting the lung with smoking exposure?
Thank you, Dr. Neptune. I think that is our last question for now.
Oh, good.
Really wonderful answers, and we really appreciate your time. Ryan, is there anything else we need to do to wrap up our time with Dr. Neptune?
Well, just thank you to Dr. Neptune for giving us your time today, and thank you for everybody for joining us. As a reminder, these webinars will be recorded and uploaded to YouTube as soon as possible once the conference is completed. And so once again, just thank you all.
And thank you guys for attending, and enjoy the rest of our virtual Marfan Foundation conference.
Good night all.